Welcome, everybody. Thank you for joining the AI in Action series. This series hopes to focus in for safety net organization and feature speakers and innovators working in the safety net setting. Today's topic is replicating an AI ML-driven pediatric asthma care model across safety net setting. And we'll feature Dr. Yolande Pengetnze and Dr. Cesar Termulo. And I'll go through the introductions and then give the floor to the presenters. Thank you so much. Welcome. So we are talking about this topic. Last month, we had Dr. Hakeem Adinei come and talk about ambient AI scribe implementation at Sacramento Native American Health Center. And today we're going to give presentation from Dr. Pen-Get-Zeh, Vice President Clinical Leadership from Parkland Center for Clinical Innovation. Dr. Pen-Get-Zeh is a pediatrician, physician, scientist, and VP of Clinical Leadership at PCCI, with more than 25 years of experience in clinical and healthcare leadership, leveraging advanced analytics, technological innovation, and care transformation to promote community health equity. And we are also joined today by, my slides forward, Dr. Cesar Termulo, Associate Medical Director at Parkland Health Community-Oriented Outpatient Clinics. Dr. Termulo strives to work within public health systems from both frontline and administrative positions to improve community health. So thank you so much for joining, and I'll give the floor to you.
Thank you.
Let me stop sharing and I will share the other deck. Sorry, I think my computer is lagging a little bit too. Okay, share. And let's see if hopefully this works and doesn't give me issues. Yeah. Is it working well? Yes, thank you.
I think so. Okay. Welcome, everyone. My name is Cesar Termulo, and I work for Parkland Hospital. Parkland is the safety net system for Dallas County. We had started an AI ML-driven asthma QI program at Parkland, and now we are working on trying to the generalizability and translatability of our program into other safety net systems. Next slide, please. So we know that asthma is an important part of the fabric of healthcare nationally. Over 4 million children are affected with asthma. Over 7% of the population under 18 years old has asthma, and it generates over 270,000 emergency visits per year. In 2020, there were over 145 pediatric deaths. And it affects those who are socioeconomically disadvantaged, and that 3.8 million in the United States live under the poverty threshold. And by race ethnicity, 12% of the Black population are affected with asthma, and 7% of the Latino population. In the patient population that I serve, it's primarily African American and Latino patients. Asthma-related ED visits are nearly 5-fold higher for African American patients compared to white patients, and asthma deaths are 8-fold higher for African American patients versus Caucasian patients. Next slide, please. As all safety net systems and public health systems are tasked with every 3 years, Parkland has to do a community health needs assessment. First of all, let me just a little bit more background in terms of the hospital that I work in. Parkland is Dallas County's safety net system with over 980 inpatient beds, over 60,000 admissions per year, over 230,000 ER visits per year, and over 1 million ambulatory visits per year. we have we have a very nice hospital in the center of Dallas, but we also have 17 community clinics spread out across Dallas County, 14 that have pediatric services. We have 8 mobile vans that provide outreach into the homeless community. And we also are responsible for providing medical services to our correctional health facilities in Dallas County, and we also have 2 school-based clinics. So every 3 years, Parkland is tasked with doing a community health needs assessments. We have focus groups. We work with the community to try to understand disparities and health issues and health needs in our community. And in 2016, we established an initiative for pediatric asthma, on top of other needs in our community that we encountered, such as mental health issues, diabetes, breast cancer, postpartum mortality, hypertension, and sexually transmitted infections. So for each of these initiatives, we engaged upon programs to try to address these issues of disparity in Dallas County. Next slide, please. So next slide. So, AI would provide a very important role in trying to take care of the population. Our largest issue is that Parkland, our entity, has over 3,000 children with asthma, and trying to provide appropriate accessibility for these patients is a challenge because most of our providers, we have doctors and APPs, physician assistants, and nurse practitioners. But even though we have a large provider population, each provider usually has at least 1,500 to 2,000 patients on their panel. So trying to provide adequate access is a challenge. And for many of our patients, there are many non-medical determinants of health that could affect their ability to access care and be able to take care of their asthma properly. So the opportunity we found is that could we find ways that AI could be leveraged to be able to provide timely diagnosis of rising asthma risk? Would we be able to remotely monitor patients in the population, so that we could be able to better determine whether a patient's asthma might be rising to a point that they might have to go to the emergency room? And can we capture a lot of the drivers that would be used to be able to predict whether a patient might have to go to the emergency room, and could we be able to provide them care when needed? Next slide, please. So the tools that we used were multifactorial. So we took a lot of in the background data sets that were running on the patient population that we had. We developed an AI ML risk prediction model focused on certain variables to try to predict whether a patient's asthma might indicate a need for rising risk for an asthma ER visit. So we developed this risk prediction model that could provide and give some substance to a 90-day risk predictive model to be able to determine which patients might need intervention. So we developed a risk prediction model that would be fed to clinicians to try to judiciously reach out to certain patients that might need help. And that was compiled in these monthly risk reports updates that were sent to at our clinic system. We have a respiratory therapist who manages these risk reports and reaches out to these patients to see if they need an appointment. In addition to that, this risk prediction model also would develop alerts into the clinical workflow of patients, so that if a patient were to come to our clinic for a non-asthma related issue, such as a headache or an ER follow-up, or they might come in for, say, a mental health issue, a BPA alert based on the risk prediction model would show up on the screen to show that a patient might need some intervention at that visit. So It was seamless and it was very easy to be able to bring to attention the need to be able to address a possible asthma issue, even if it's not something that's on the top of the mind of the clinician that's seeing the patient. So basically, a BPA alert would show up on the screen. Next is that we would try to remotely monitor patients on their current asthma status, and that they would biweekly receive a text message and a query in terms of how their asthma was doing. It was basically two questions that they would receive. The first question is, how's their asthma doing today? And then the second question is if they've missed any doses of control or medication. So the responses were compiled into another report that was also fed to our respiratory therapist. Our respiratory therapist would then try to reach out to those patients that mentioned that they might be having more problems with their asthma and they might have missed more doses of medication. He would perform the asthma control test to determine if those patients needed to be seen in the clinic. So in that fashion, we're able to try to bring these patients into the clinic, even if they weren't currently on our radar in terms of patients that needed to be seen, or they didn't have any appointments, they didn't have any schedule to be seen by the clinicians in our clinics. So in terms of creating this risk prediction model, next slide, please. For this risk predictive model, there are certain variables that are fed into the risk predictive model. These are the variables that were fed into it, and based on how the patient is doing with these variables, it would help us to be able to predict how their asthma might be doing. So it was variables such as relievers that were being used in the past 12 months, control medications that were used in the past 3 months. So you can see that the data sets were coming from very different places. It might come from the EMR, it might come from pharmacies in terms of medication utilization. Are they visiting the clinic? Or are they canceling appointments? Obesity, age group, smoking or past exposure to passive smoking, and also ethnicity. So these things were compiled into a risk predictive model that tried to determine whether there might be rising asthma risk for a particular patient. Next slide, please. And I believe Yolande can speak to this slide.
Well, thank you so much. I'm Yolande Pengetnze. I'm a pediatrician with the Parkland Center for Clinical Innovation, PCCI. We are a data and technology innovation nonprofit that works with safety net company or organizations, and we are embedded with Parkland and other safety net groups. And we and Dr. Termulo and the team worked with us in building this AI-driven model. And like Dr. Termulo said, the data that was leveraged from the EHI, in this case, pulled data from different sources to predict the risk of a patient ending up in the emergency room or in the hospital within the subsequent 3 months. And then the insights for those data were compiled into reports that are distributed to providers so that they can intervene, and to case managers, into disease management teams, respiratory therapists, community health workers. And to the right, we're showing you different ways that the tool was implemented. Folks redesigned their workflows. We had the point of care alerts. Some kids, patients were prioritized for scheduling. Some folks use this to prioritize spirometry testing or allergy testing. Community health workers leverage these reports to outreach to patients. Providers use these reports for medication management, and at the same time, the text messaging were tailored to address the patient-specific risk factors. Next slide, please. And this is just a sample of the text messaging program, giving you a general sense of how it worked. Against 80 short messages that are sent 2 to 3 times a week to educate patients, and then the 2 items asthma symptom survey to assess how their symptoms are and prepare a report that is sent to providers, and then a quality satisfaction survey that's sent on a quarterly basis to assess how patients perceive the program in general. And again, this program targeted mostly very high and medium risk patients, but again, added to it any patient that the provider would deem that could benefit from the program. Next, please. So these are the impact at Parkland. So the program was started at 2 levels in Parkland. We're talking about generalizability. It didn't start in the clinics. It started with the health plan that's affiliated with Parkland, the Parkland Community Health Plan in 2016. And because the impact was positive, it was translated into the Community Health Needs Assessment / Parkland entire population, regardless of who, whether or not they were insured and who was their insurer. So these are initial impact data. We had about 5,000 patients we stratified on an annual basis. Right now, we have actually more than 3,000 patients enrolled in the text messaging program. And within the first 12 months of implementation, we saw a 36 to 42% reduction in asthma-related ED visits. Next slide, please. And these, again, are in-depth results. So in the PCHP population implementations in 2016, as you can see to the left, there was a trend towards improving asthma-related ED visits when we looked at the Parkland Community Health Plan patients, and even when we compared them with non-Parkland Community Health Plan Medicaid patients. While there was overall improvement trends, the Parkland Community Health Plan patients had a more substantial drop in asthma-related ED visits of 42%. And to the right, that correlated with a drop in asthma-related cost of 32%. The next slide shows you how this worked when we transferred it strictly to the Parkland Patient the Community Health Needs Assessment Plan. There was a 36% drop in asthma-related ED visits, a 60% drop in asthma-related hospitalization. Next slide. And a 59% drop in asthma-related systemic steroid use. And to the right there, it's a little tiny, but that's basically us looking at quality outcomes, patients' response to the program. So for the most part, over 85% of patients were satisfied with the program, felt like the program taught them something about asthma, and 91% will recommend the program to friends and family. Next slide. So since this program had been successful at Parkland, which is a large academic safety net system with more resources than other safety net systems, the question was, can we expand this model to smaller safety net providers like federally qualified health centers? And if so, what does it take to expand it? How does the data model work? How does the clinical model work? What are the adaptations that need to be done? And do we have any pathway to sustainability? So to the left are the different aspects of the program that the way we designed it. So the plan was to test, retrain, and recalibrate the model as needed to ensure that we monitored it for biases and adjusted it accordingly. Continue the multi-stakeholder engagement, just like we did at Parkland. Here, since it's a testing, it's a clinical trial, we designed it in a way of pragmatic trial, making sure that we adapted all interventions to the context of each one of these clinical sites. We picked clinically relevant outcomes that are not only useful for patients, but certainly useful for quality metrics. And then we are working on the long-term sustainability. So we're going to be looking at the cost analysis to ensure that these programs, once they're set up, can be sustainable. And to the right is just a consort diagram that tells you how the clinical trial is designed for these two organizations with a 2-to-1 randomization scheme to intervention patients, providers to one control provider. And this is a cluster randomization scheme. Next slide. But today we're going to talk about mostly the models and the lessons learned so far in translating this model from a large academic setting like Parkland to smaller settings like the two FQACs we're working with, Foremost and Lost Barriers. And while we didn't get a chance to introduce them, Foremost is two location, large FQAC here in North Texas that has a predominantly African-American population, whereas Lost Barriers is multiple locations as well, FQAC here in North Texas that has a predominantly Hispanic Latino population. So a few things to consider, and this is both foresight and hindsight. Clinical documentation. These can vary from one site to another and might affect data recording, data quality, and data completeness. Data accessibility and quality. So the way data is stored, where the data is stored, how easy it is to retrieve it, what is the accuracy of the data, again, the completeness of the data. Are there biases that may be introduced in the way the data is recorded, stored, or extracted? Those are things that are important to consider. Technology integration. One of the things we learned is that EHR functionality can vary widely from one setting to another, depending on the level of functionality that is provided or purchased. And while in most clinical settings, EHRs are meant to be good for clinical documentation and reports and certainly billing, there could be some substantial limitation in the ability to pull custom data and to do such pull frequently. There could also be a limitation in interoperability and data readback capabilities. And then there could be, and we encounter some legal hurdles with accessing backend data in those EHRs. Now, there are resource limitations and clinical workflows differ from one site to another. FQHCs have limited resources. Provider panels, meaning the number of patients that a provider takes care of, is typically heavy. Providers have a very busy schedule and they take care of patients who are medically and socially complex, and therefore interactions are typically fairly involved, and they tend to rely more heavily on allied staff like community health workers, case managers to support the processes. There's also the notion that the population and the cultures that those populations live in might differ from one site to another, and that's something that might affect model generalizability and equity. And last but not least, as discussed, it's important to think of long-term sustainability and align with business and cultural organization culture to ensure that we drive engagement and sustainability. So the key takeaways here are we have to prepare to adapt, think creatively, and prepare to collaborate. Next, please. So we moved on to looking at the data itself. And the first step was to take the model that was built at Parkland and assess how it performed at both sites. And what we can see here is that the Parkland model, its performance substantially deteriorated when it was applied to data both at Lost Barriers and at Foremost. So you can see to the left, the Parkland model has a precision of 30% when you look at the very high risk group. We're going to focus on that group. The recall is 8%. It might be small, but it's good enough to pull in enough patients for the workflow to be supported. But then when we implemented that model as is at Lost Barriers, the precision dropped to 2.3%. However, the recall went up to 82, which means here that the model at Parkland tended to classify close to 72% of Lost Barriers patients as very high risk, compared to only 2.5% of Parkland patients that were classified as very high risk, and that was by design. And then the same model implemented at Foremost, you could see the precision at 4.5%, again, compared with 30% at Parkland. The recall is high, and again, telling us that the model is classifying a higher proportion of Foremost patients at high risk compared to Parkland patients. So what we could say here is that while the recall was high, the precision was low, the discrimination was poor because the goal here is to discriminate among these patients, not to classify everybody as very high risk. Next, please. So the one before. Back one slide, please. So the next step was to recalibrate the model. So here I'm just showing you the calibration at foremost, but we had similar results at Parkland. So to the left, again, the Parkland model as it performed at Parkland. To the middle, the Parkland model as it originally performed as is at foremost. And then to the extreme right there is the Parkland model once it was optimized, which means the variables were optimized, recalibrated. And what you can see is that while the precision came up to 12.1%, still not at the same level as Parkland's, the recall dropped substantially to 11%, which tells us that it feels like this model, we just can't find the right optimization to make it to perform at a reasonable level. So the next slide is us then moving to the next step, which is we need to retrain the model. We need to create a new model. And what we did was we had to pull in new variables. We had to look at new data sources, including data sources for social determinants of health at the neighborhood level. And then we had to look at new modeling approaches, looking at tree-based models versus the regression model. So to the left, just again, reminding us of the Parkland model, it's a 9 features model. So a model that relies on 9 variables. It's a lasso model. It's fairly parsimonious since it only had 9 features, and it's explanatory since it's a regression model. And as you can see, the variable categories are mostly patient-level data on medications, utilization, clinical variables, demographics, social determinants of health at the patient level. But then to the right, the loss barriers model, the best performing model at loss barriers was a tree-based model. It was less parsimonious, uses 36 features. And therefore, because it's a tree-based model, they are typically less explanatory. And as you can see, while variable categories were fairly similar in terms of utilization, medication, the model was substantially enhanced by adding to it neighborhood level social determinants of health, which helped us capture information like smoking, which was poorly documented in the EHR, but yet at the neighborhood level had a strong effect on the model. So those are data adjustments and modeling adjustments that helped create a model for loss barriers. And the next slide is going to show you how this model performs. So to the left, it does this loss barriers model, the 36 variable loss barriers model. And to the right, again, a reminder of the Parkland model. And the loss barriers model actually performed better at loss barriers than the Parkland model at Parkland. So the precision here in the very high risk group goes to 50.7%, which is 51%. And the recall is 29%. And what it means is that 1 in 2 people that we predict as very high risk are going to end up in the emergency room within the subsequent 3 months. And 1 in 3 people who end up in the emergency room will be classified as very high risk. It truly is a very robust model. So very high precision, very high recall. But like we said, since it's a less explanatory model, the adaptation we made here in implementation was to create more explanatory reports. That is, if the model itself can tell us which variable is driving these, we're going to then provide folks with specifics about the variables that we know drive these risk and are associated with every specific patient. Next slide, please. So that was the activities that we performed at to adapt the model and make it generalizable and adaptable to help support a similar AI-driven model at foremost and loss barriers. And here we're summarizing the things we've learned, and these include how the clinical and the data model adjustments had to be performed. So one of them was clinical documentation. Like I said, things are documented differently in different places. While some people document information in a workflow and systematically in their workflows, other folks would document it as needed and per patient's request. So it was important to understand the differences in documentation and implications for data quality. And like I said, because some data were incomplete in the EHR, we had to look for alternative data sources, like supplementing the clinical data with some social determinants of health data at the neighborhood level. Data accessibility and quality, again, data storage, retrieval, like we said, are variable from one place to another, but at FQHCs and safety net systems might be a specific challenge. So we had to switch to looking at like raw data access. Can we just access data in a data lake? Strong QA steps. It was essential to review the data and make sure that the quality of the data was good enough for the model to be adaptable. Like I said, pull new data sources, recalibrate the features, and features here stand for variables. Retrain the model as needed, as it was required in this case. But just as important, we are setting ourselves up for model performance and model impact monitoring, because it's important for us to continue monitoring this model for biases that may appear, disparities that may appear, not just in the model's performance, but on its impact during implementation, focusing on specific subgroups like racial, ethnic minorities, and patients with specific social challenges. In terms of technology integration, given the limited EHR functionalities that are inherent probably to the quality of or the purchasing power of FQHCs, it was important for us to set up data access workarounds. So in this case, we looked at two options. One was accessing data lakes on the back end, and the other was batch data dumps that would be put in one of our data lakes, and we'll pull those and run analysis on those. One other aspect is incorporating manual steps. That is where we wanted to create a complete API-based functionality. In this case, because of the limitations of APIs with these EHRs and the limitations of existing reports, we had to incorporate some manual steps, and those manual steps are what drove the data dumps. We also have these periodic reports. So we were planning and we're hoping to build point of care alert in the EHRs, but the read back functionalities in those EHR was limited, if existent at all, based on the versions that we had access to. So we had to adapt to creating more periodic reports and looking at existing reports that we could supplement with the information that the risk model provided. And then in terms of legal hurdles to access the backend data, one of the solutions that we looked at was to leverage existing contracts and agreements so that we didn't have to recreate everything from scratch. Now, resources are limited, and clinical workflows are different from one step to another, like we saw at safety net organizations in FQHCs in this case. So one thing that we did was to leverage other safety net resources. And then it may not sound like very much AI associated, but AI can only work if it's incorporated in appropriate workflows to help folks reach patients where they are. So in this case, we work with the Dallas County Health and Human Resources team, human services team, who would receive the reports that would normally be going to the FQHCs and support them with patient outreach and public health interventions, community outreach to address asthma in their community based on the insights provided by the report. And I believe having a dedicated data and technology support team is essential, because many safety net organizations cannot afford to have a dedicated data and technology support team, and those limitations will certainly preclude them from fully implementing AI-based models. So the PCCI team, as a dedicated team, was support to this system. And then in terms of population and cultural differences, we leverage subject matter expertise from across the different organizations from Parkland to Los Barrios Foremost and PCCI, so that we could ensure that the data that we pull and the insights that we provide are translatable and interpreted correctly. Because again, these are populations, while the model is built in these populations, it's important that the model actually translate what is true and real for these populations. And then last but not least, the long-term sustainability. We can only engage businesses, and businesses can only engage in implementing AI if we can show to them that it's not, again, one of those one-offs that they'll implement and then they won't be able to sustain. So we're in the process of developing a sustainability framework, which is why we have a cost analysis embedded in this program, and the outcomes are very much targeted to ensure that they align with business needs and organizational culture at foremost and at Los Barrios. And I believe the next slide, that's probably the last slide. And so that is truly our experience with implementing AI at a large public health system and then translating it to smaller safety net systems. And again, a bunch of these are things that you're familiar with, barriers that you've probably encountered, but some of it are fairly specific to leveraging AI and data-driven interventions to penetrate these safety net populations, which I believe stand to benefit the most from AI by uncovering their specific needs in a timely manner and reaching out to them in a tailored manner, because they may not be as responsive to usual approaches to quality improvement and population health interventions. That's it for our presentation. Thank you, and we're open for questions.
Thank you so much. I think we can open the floor for questions. Thank you so much for sharing your experience. I see Varun has the first question. Varun, you can unmute and ask your question if you would like.
Of course. Thank you so much for a wonderful presentation. This is just so awesome to hear both the technical specificities, as many of us are trying to understand how to do this in different contexts. Yolande, I guess my question is for you. All of the workarounds that you found a way to do with safety nets seem like things that often have to happen on a one-to-one basis, because just how to scale that out. I can totally see how there are different parts of this that you're abstracting away to be able to do it somewhere else. How much of that is possible if it's the same EHR systems that you know versus it's a different IT stack altogether, and now it's like, you know, maybe they don't have the money to afford Epic, or they're on next gen, or something new that comes up that's maybe cheaper. I don't know, but just be curious for your thoughts there.
Oh, that's a great question, Varun. So that is exactly what we are, or the situation we are in. So Parkland has Epic, but Los Barrios and Foremost have two different smaller EHR. And Parkland has a full functionality of Epic, but Los Barrios and Foremost have, you know, like functionalities that are fairly specific to their workflows, what they're trying to accomplish. So that explains in part why we had to do quite a bit of work around to ensure that they could benefit from a model, right? And then the fact that we're going from one system to another, folks document things differently, right? In some places, they systematically document social determinants of health, in others, they don't. Some systematically document smoking cessation or smoking exposure, others don't. So it feels to me that the one of the lessons learned from this generalizability is adaptability. That means it's going to be fairly difficult. Maybe after we implement in 2-3 places, there will be some common patterns that we can then use across the board. But for now, it feels like the primary common pattern is test, adjust, and then adapt. Right? So test the model, adjust it, retrain if needed, and then adapt your workflows to ensure that these models are implemented in different places. And truly, one lesson learned that I haven't put here, it may sound political, but I think it's important that in the funding of FQHCs, if we want them to benefit fully from the promise of technology and AI and all these different tools, it kind of would be important to incentivize them one way or another to be adapting these technologies. And in my opinion, these safety net populations again stand to benefit the most from these new technologies, but that's if we can bring it to them. And here we're not even bringing it directly to the population, we're just bringing it to their providers, and it's already that hard, right? You can imagine that it'd be even harder to bring it straight to the population, but at least to the provider, maybe create some incentive, a card in which they can fully implement these tools, if that makes sense. And I hope that answers your question.
Very much does. And you brought up something that's so important that I would want to ask a follow-up question. And Cesar, I think this is a question also for you as well. You mentioned creating the incentives for FQHC specifically to implement and think about these models that I think, and this is just from hearing you speak about them, really helps them transform their internal capacity rather than rely on maybe sort of point solutions here and there off the shelf that could cost up to, well, who knows how much. And yet we're not seeing that because of the federal funding budgets and cuts. Where is the opportunity to meet both this sort of demand for ROI, for budget lines that make sense, especially as HRSA 330 grants might be going away soon, as much as Medicaid might be going soon, with sort of having to spend a lot of time doing that one-to-one clinical data matching to make it work? And I'm assuming I'm not even touching training staff to use the algorithm once you've already built it. Are there use cases that you see where it sits right there in between, or is there still work to be done to bring parties to the table together?
I can take a stab at it. And we have our FQHC partners actually on the call, so I may call on them to respond to this. But the truth is, the reason we picked asthma is because asthma is a huge cost driver and it's a quality driver. And those two things matter to people who hold the purse strings. So while, we would love to do a lot of things with AI, we kind of have to focus it on those intersection, those conditions and situations where there's an intersection of common interest between the healthcare providers, the community, and the payers, right? So in this case, for instance, with asthma, as we demonstrated with the Parkland and the Parkland community health models, that there was some cost savings. If we can demonstrate some cost savings here, then we then have a leverage to further engage payers. And this is not us coming to the table and begging for money. They will be paying for those emergency room visits one way or another, but it's us coming to the table and saying we can help prevent emergency room visits, but you would have to create some shared savings situation in which you pay a little bit so you can earn a little more. But again, I am not the most sophisticated person to talk about this. I think Dr. Sharon Davis and Dr. Naomi Gabriel are on the call. They are medical directors at Los Barrios for Dr. Davis and at foremost for Dr. Gabriel. But Dr. Davis, Dr. Gabriel, do you have any insights to share with the group?
Well, perhaps I can comment on one thing. I think one thing is that we are in a unique position in that there's Parkland, which is the clinical entity, and there's Parkland, which is the community health plan. And so we work a lot with things like metrics, and we work a lot with incentivizations with a community health plan. So I do think that, some levers that can occur would be with the program that we've done. If we are able to show cost savings with the community health plan, there is a way that the insurance plan can also the managed care organization can help us as well with the things that we're doing. So I think that's one unique situation that we're in is that we're somewhat married to this other organization that kind of holds some of those purse strings.
Yeah, so this is Sharon Davis. And I would agree with actually both of what they have said. Keeping people out of the emergency room, of course, is a big deal in a lot of these cost saving, shared savings programs. But also, a kind of a side effect of this is that we find that they're also more engaged in the healthcare system, period. So they're like other things that we would get, for instance, things that we get paid on for value-based care are numbers of immunizations, well visits. And while it doesn't necessarily directly have to do with asthma, we find that these kiddos that we're really taking an interest in to manage their asthma, they're staying up to date. They're getting their flu vaccines, they're getting their well visits done on time because they're much more engaged with their primary patient-centered medical care home. So that's kind of where we see it.
And thank you so much, Dr. Davis. And Mr. Mitchell, Heron Mitchell is raising his hand. He is the CEO at Foremost, so his insights might be helpful as well.
Thank you, Dr. Pengetnze. I would just like to commend you on your work and in the beautiful presentation. It was a heavy lift, and you, Dr. Pengetnze and her team had to walk us through. So I just want to. I know that she's very eloquent in going through her presentation, but it was a tough deal to bring us to the table, and she finally got us through along with Dr. Termulo. But just as you all were saying, for us in the FQHC space, especially in recent times, we are incentivized by everything you've said, along with our value-based contracts, specifically about the ED and our ability to keep our patient panel out of the ED is not just good for the patient, but people like Molina, people like WellMed, other payers are incentivizing us for a population that is higher acuity to keep them out of the ED. So brilliantly aligning this with, the goals, the quality goals for care for the patient, plus with our bottom line, and giving us a little bit of help with resources actually got us. We would never have achieved this in 2 or 3 years without the expertise that's behind it. So we like to thank the team for that.
Thank you, Mr. Mitchell.
Thank you so much. That was great discussion. If people have other questions, please definitely raise your hand or put it in the chat. But following up on that discussion and what Dr. Heron just commented on, I think one question I had, Yolande, is once you started this project and started to think about expansion into the 2 FQHC systems, what did that process look like? Could you talk a little bit about the timelines and what people did you have to engage? And given the resource constraints in the FQHC settings, what kind of people did you have to either upskill or hire to make sure that this work happens? Who are the people and processes behind the scenes making this happen? Just talking a little bit about that.
That's such a great question. It can take us way back then because this is a program, ever since we started working with the Parkland Community Health Plan, we have wanted to do it and we did a model at Parkland. We had wanted to do it at the FQHCs because Los Barrios and Foremost are long-term partners of Parkland, and it was becoming a little bit, it felt a little inequitable that we would be implementing a program like that for patients who are covered by a specific insurance, but not others. And they were asking for it, but the opportunity came when this grant, the Aim High grant came from Cesar and Gordon and Betty Moore Foundation. We applied for it, and once we got it, that was the impetus for this to work to work out. And like you said, then it was time to have to ramp up the personnel. I would say two of the biggest hurdles are one, having a dedicated personnel to support data and technology. So it's just fortunate that PCCI is set up in the way we are. We are here to specifically support safety net organizations with data and technology needs. So we had the staff inside to do it. Would we have had to implement this in a different setting with different folks? We would have had to ramp up recruiting staff and bringing them up to speed and having to educate and train and whatnot. It would have been probably a little more complicated. So truly, that's one of the key takeaways, is that if there is any way of leveraging organizations that have expertise in helping these or the small organizations, is very important, because they will not have a dedicated data team, they will not have a dedicated technology team, and not every data and technology team might be comfortable with the kind of data they have. You have to do a lot of troubleshooting. So I think the more we have organizations that are set up to support these kinds of initiatives, the better. Second is, of course, the clinical workflow. So that's where we had to adapt. That's one of the things we had to put our heads together and think, okay, we just don't have enough staff to do everything that's supposed to be done. And now you have these great insights and you can intervene. How do we do that? The good news is, through the CHNA implementation, we had engaged the Dallas County Health and Human Services team, and they are very keen and interested in working with different groups to address asthma. They have an asthma program. So we turned to them and they were eager to step in and support the staff. But the idea about making sure that we ramp up the staff was also one of the ideas behind building a sustainability framework. Because when the grant fades away, how is this program going to be maintained? And it's when, we're going to come back with cost analysis. We have a couple of payers on the table that are discussing with us in understanding how this program impacts the population, like Dr. Davis and Mr. Mitchell very nicely articulated. There are benefits beyond asthma to the population that folks are focusing on, looking at their vulnerabilities, because while these vulnerabilities address asthma needs, they also tend to address other needs and therefore make for healthier populations. So we're talking to a couple of payers that will come to the table to review with us this sustainability plan so that we can set them up for long-term success. So it's a matter of building the team now to meet the needs for this specific implementation, but also setting up a long-term sustainability framework for these FQHCs, and hopefully that other safety net systems can learn from as they set up their own programs and they try to adapt to this AI-driven environment.
I would like to highlight one thing. It is that I don't think this project would be able to fly if Parkland were doing it on its own. Parkland has its own EHR and technology team as well that's running reports on things like metrics. But we're so busy with just the regular operations of running the hospital. It really took another organization that can be focused on clinical innovation to be able to get this project off the ground. So this would not have taken place if we did not have a partner such as PCCI to be able to drive this model. That I know that for sure.
Yeah, the pockets of possibilities that you have to create in different places. That's awesome. No, I think it does take a lot of multi-stakeholder effort to put something like this off the ground and then spread it across different institutions. So this is great insight. I think I have one last question. Manesh Samtani, I think you sort of answered that question in our previous discussion, but I'll still bring it up. I think his question mainly is how are these systems going to buy or procure these kind of tools? I think what your example is, it's sort of in-house custom build for the two FQHCs, you localize the models for their needs and ensure that they performed well for their population. And then you're already working with the payers to define sustainability. So I think that sort of you've answered how do you buy and then how do you sustain? Do we charge the customers? Do we charge patients? Do we charge payers for these services? In future, if you have any comments, how would AI systems get implemented? I think there are many models, but yeah.
I think if we can show that these systems bring value in the system, are cost effective, then, in the process of actually funding FQHCs, right? I don't know, HRSA grants can be adapted to have a portion of it that supports, that's the impetus, that's the upfront investment in supporting these kinds of systems in a fairly specific manner, but still, that would be an investment upfront that would hopefully help decrease the healthcare cost down the line. But it is important to have demonstrated that these work and save cost and save lives and improve quality of life, improve productivity in the community. So it's important, and that's why for every one of these programs, important to look at it on the broad lens of society, not just, is it a great implementation that works for the system, but does it actually impact outcomes and the outcomes that matter from different stakeholders' point of views. And when we do that, then we can convince folks not only to put in the upfront funds to start the programs, but also to continue sustaining it as cost is being saved, having folks like, health plans be some sort of outcome buyers that come in and pay extra so that their patients can be maintained using these AI tools. So I think it's just a combination of thinking about incentives coming from different versions of folks who have a good reason to pay for these outcomes.
Awesome. Thank you so much. This was a great discussion. I think we have a lot to think about. And thank you so much for your time. And thanks everybody for joining. We have recorded these sessions, so we will post it on our website soon, and will be circulating in our newsletter. So thank you so much, Dr. Pengetnze and Dr. Termulo, for joining us.
Thank you for having us. Have a good one.